Okay, so great. It's almost 8:30, so let's begin. And just a few housekeeping announcements. So we are in the last part, the fourth. Yes, so I'm sorry for the audio. Yeah, so we are in the last part of fourth part of this LIPAGLYN MSLD Pro series, where we'll be discussing about the management, the most important aspect, that is the management of MSLD. And just a few housekeeping announcements. So again, I put the link for the access to the technochronology.com website for this particular course. You can see the link in the webinar chat. It will also be there on the YouTube video description soon. So if you're not done so, please go there and sign up. Now you'll be able to get your certificate by end of the presentation today. I'll show you how you'll be able to get your certificate for the same. So please hold on to that last part of the lecture to really see how to get your certification for this particular course. Okay. Another important announcement now. So this has been conveyed to me by the LIPAGLYN team, and this is very important. So LIPAGLYN team has fibroscan machines across the country. Currently, they are conducting fibroscan in almost every district in India for your patients. Okay, so it's very important for you to note that if you have any patient for whom you'd like to conduct a fibroscan, what I'll suggest is get in touch with the Zydus team, the ones who handle LIPAGLYN division. Please get in touch with them and they'll be able to provide this as a value-added service. Again, it's a service from their side, and it will be very helpful for your patient, for management of your patients. So even if you're from a smaller district or smaller town where fibroscan machine may not be available very easily, you can talk to your Zydus representative to help you with this process. So that was all as far as the housekeeping announcements are concerned, and I welcome you all to the last part of the series. I hope you really have enjoyed the learning as much as I've enjoyed teaching this course. I think it has been a fantastic experience for all of us. Let's begin with the first presentation on this topic. Just give me one moment to share my screen. Yes, so we are on the fourth part of the series, and this is the concluding part where we'll be discussing the management of MASLD and the basic principles of management of MSLD. So let's begin with the principles. We'll discuss everything. We'll discuss most possible drugs. We'll discuss the upcoming drugs also, and we'll be discussing lifestyle measures, bariatric surgery, everything. Okay. So hold on to your horses. It's going to be a long lecture. I was told last time that we were rushing through, so let's take it a little slow. Let's not rush through it. Okay. So let's begin. Okay. So let's first start with this principle. Okay, so which patients require treatment? Okay, so which are the patients whom you should consider any form of treatment? So I think it's needless to say any patient who has MASH, that is metabolic associated steatohepatitis. Now, if you remember last time in our last lectures, we had clearly discussed what is steatohepatitis, and we had also discussed that steatohepatitis is very difficult to diagnose non-invasively. However, what you can use is you can use what is known as a FAST score. The FAST score is available on the technochronology platform. For that, you'll require a liver function test and you'll require a fibroscan, okay, to calculate the FAST score. And you can also use a MASLD score where you can use an MRI to sufficiently diagnose steatohepatitis. Secondly, if the patient already has fibrosis, and remember, if you see the stages of fibrosis, F2 and F3 are the stages where intervention should be considered. And again, these are the patients you should consider treating. Again, patients with comorbidities. So patients who are having type 2 diabetes and obesity with MSLD, you should treat the underlying disease as well as MSLD. And patients who are already super obese or obese, where bariatric surgery is an option, all of these cases should be considered. However, having said that, All MSLD patients, lifestyle modification should be offered to all patients. You should manage the comorbidities. Remember, I always used to remember that, when I was a student, we used to have this multiple choice question. What is the most common cause of death in patients with chronic kidney disease? Most common cause of death in patients with chronic kidney disease is actually heart disease, cardiovascular disease. Same way, in patients with MSLD, the most common cause of death is cardiovascular disease and not MSLD itself. So most of these patients are having very high risk of cardiovascular disease, and hence they are more likely to develop cardiovascular complications. So cardiovascular assessment and treatment with statins are a must in all of these patients. Remember, also, I'll repeat this in upcoming lecture also, statins can potentially increase the liver enzymes transiently. However, having said that, despite this, the statin should be given in these patients without fail. Okay, so you can see in this cartoon, the management of these patients. This is looked at the entire picture, right? So lifestyle modification, pharmacological management, bariatric surgery, and of course, any patient with cirrhosis, end stage, liver disease should be considered for transplantation. And apart from that, you treat the comorbidities which are given on the left. That is the cardiovascular disease, type 2 diabetes, atherosclerosis, sarcopenia, obstructive sleep apnea, osteoporosis, chronic kidney disease, hypothyroidism may be linked. We've seen some of patients with hypopituitarism and malignancy if there is any, right? So all of these things should be looked at when comprehensively managing a patient with MSLD. Okay, so we have to remember that the management of MSLD, the medical management has to be stage F2 and F3 of fibrosis. There is no targeted therapy for end-stage cirrhotic disease. So last time somebody was talking about cirrhosis, somebody or patient having already decompensated cirrhosis. In such cases, there is no treatment currently recommended for cirrhosis. I mean, of course, you treat a cirrhotic patients in the other ways, but as far as the MASH related treatment is concerned, they are mainly for patients who are having F2 and F3 fibrosis and not patients with end-stage liver disease. Okay. So we already discussed what are the options we can use for management. So you have lifestyle measures, pharmacotherapy, bariatric surgery. In this first talk, we are going to discuss about lifestyle measures, and then we'll go on to talk about pharmacotherapy and bariatric surgery and other treatment options also. So what's to do as far as lifestyle modification is concerned? The essential thing, and this is very, very important for all patients, there are two things you have to do. One thing is try to reduce weight. Okay. So patient with MSLD, the aim should be 7 to 10% weight loss. That should be that, and that is enough often to reverse and improve steatohepatitis and also early stages of fibrosis. So F2, F3 stages of fibrosis also can be reversed with weight loss. Second very important thing is alcohol consumption should be minimum or zero. Okay, so there is no safe level of alcohol consumption as such in a patient with MSLD. If you remember my very first talk, we had talked about a lot of these patients are also taking alcohol, and hence there is a lot of these patients have MetALD, that is metabolic associated disease with alcoholic liver disease. Also, you have to remember that any form of alcohol intake, if the patient already has MSLD, it can give a second hit to the liver. And liver, we always remember, decompensate faster when you have two hits. So if you already have MSLD and you consume alcohol, you are putting a second hit on your liver, and that is ultimately what leads to more complications for your patients. What about pharmacological interventions? Okay, so if you have a patient with MSLD and type 2, you have certain drugs which can be potentially given. We'll discuss all of these things in detail. If you have type 2 diabetes with MSLD, you can give this patient tirzepatide or semaglutide, which is GLP-1 receptor agonist. You can consider SGLT2 inhibitors, and you can consider pioglitazone. If the patient does not have type 2 diabetes, then you can consider other treatment where two drugs are absolutely useful: resmetirom, which is still not available in India, and saroglitazar, which we'll discuss in detail, which is available in India. Statins should be given to all of these patients for cardiovascular risk reduction. Again, automatically, if your patient is having MSLD, the indication for statin is automatic because this patient automatically is put into cardiovascular risk. What about aspirin? Aspirin, we discussed last time in one of the earlier lectures that aspirin does have benefit as far as prevention or progression of MSLD, also reduction of cardiovascular disease. However, some of these patients may be at a higher risk of bleeding, and older patients will be higher risk of bleeding. So whether to give aspirin or not for primary prevention, you have to see the benefit versus risk. Whereas in younger patients where there is no other complications or no other risk factors, aspirin should definitely be considered. And vitamin E has role in non-diabetic individuals. We'll discuss an important trial which looked at vitamin E use in such patients, and we'll see how it benefits these patients. So what are the principles of pharmacotherapy that you have to keep in mind? So any drug that you are potentially considering for treatment of MSLD, these are the things you should keep in mind. Remember, is the treatment specifically approved for MSLD, or is it a medication for some other reason which is repurposed for MSLD? So that's a very important thing you have to keep in mind. Does the treatment offer advantage beyond weight loss? That's very important, because remember, any drug which will reduce the weight reduction itself helps MSLD. So does the medication which you are giving also help beyond the means as far as the weight loss is concerned? So again, that's something you have to keep in mind. Again, this is more of from a research perspective rather than from a potential clinical perspective. Anything that leads to weight loss and improves the patient, great. What's the harm? But what you have to remember is that from a research perspective, you have to see that whether there is benefit beyond weight loss. Are there any safety concerns or contraindications, which is obviously important? Can the drug reduce or halt inflammation, right? So does it reduce the steatohepatitis? That's again something important. Does it prevent or slow fibrosis? Again, that is important. So that sometimes there are certain drugs which only correct the SGPT, SGOT numbers, but do not improve fibrosis or do not improve inflammation. And you have to see whether the drug which is being prescribed has these benefits additionally, apart from the other benefits which is had. Can it reverse and establish fibrosis? So patient already has fibrosis. Can it reverse the fibrosis? And that is also you have to look at when you are potentially considering a drug for pharmacotherapy. Now, that doesn't mean that you don't use drugs which don't have all these properties. What I'm trying to say is that a complete and more comprehensive look at the drugs should be looked at, especially when you're looking at from a research perspective. Okay, so what are the benefits of weight loss? We already discussed that a 5 to 10%, that is 7 to 10% weight loss is generally helpful. What studies have shown that about 5 to 7% of weight loss can produce benefit as far as the NFLD scores are concerned. But more than 10% weight loss definitely leads to improvement with inflammation and also some amount of reversal of fibrosis also. Right. So I want to show you this important, picture, important slide that I often show. This is made by me. This is seen, I've shared it in many forums earlier as well. How does weight loss correlate with, how does the magnitude of weight loss correlate with the improvements in MSLD? So 5% weight loss leads to regression of steatohepatitis, that is the fatty component of the steatohepatitis. 7% leads to resolution of MASH, that's steatohepatitis. 10% leads to fibrosis regression. And 15% also, if the patient already has diabetes, it can also lead to, as you saw from direct study, 15% weight loss can also lead to temporary diabetes remission also. So the magnitude of weight loss also has significance as far as the overall clinical outcome of the patient is concerned. Okay. Let's then look at the diet aspect. Now, are there any specific diets that have been shown to be beneficial in patients with MASH or with MSLD? Mediterranean diet is one diet which has, there are several studies which have shown benefit as far as MSLD specifically is concerned. However, other diets also can be useful. Low carb diet, there is a diet called Eat Lancet diet. I'll talk about this in a minute. There is intermittent fasting, which can help, and high fiber diet. All of these diets have shown some benefit as far as the MSLD is concerned. But if you have the highest evidence, maximum evidence comes from Mediterranean diet, and Mediterranean diet has shown to be beneficial in such cases. So overall, grossly, if you talk about key recommendation, you have to increase the whole grain intake, plant-based proteins, fish, seafood. Reducing red and processed meat. Again, there should be less amount of red meat, more amount of plant-based proteins that should be considered in such patients. And again, there is some evidence for it, mainly coming from Mediterranean diet studies, but not many depth of evidence as far as nutrition is concerned. See, nutritional science is very non-specific. So again, there'll always be, ifs and buts, right? And calorie restriction should be looked at as far as the management is concerned. There is a diet which the Lancet Commission for Obesity has come with a diet called Eat Lancet diet. Again, it's a more generic form of diet, just like DASH diet or some other such named diets. There's no specificity here, but basically it's just like any other diet. It is rich in whole grains, fruits, vegetables, legumes. It emphasizes on plant-based proteins and healthy fats and reduces red meat, ultra-saturated fat, and all that. Okay. And these studies, there are studies which has now shown that there are some benefits as far as the Eat Lancet health benefits are concerned. Okay. Now, this was a question which somebody had asked last time also. So let me just clarify. And this is again an important aspect of management. How frequently do you test these patients and what are the frequency things? This is a very important slide. So again, you can take a screenshot of that. The slides will be available on technochronology.com also. So you can have a look at those slides as well. So what are the things you have to do in terms of follow-up of a patient whom you are treating for MSLD? So if you have a fibroscan available, like we discussed, fibroscan, if it's not available in your city or in your district, you can talk to your the Zydus representative, and they have told me that they will make sure that fibroscan is available everywhere possible in most districts of the country, including rural areas also. So talk to your representative who deals with LIPAGLYN, and they may be able to help you as far as getting a fibroscan is done. Uh, so fibroscan, should be done ideally every year, right? So annually, you should consider doing a fibroscan. And what you should be looking at is the liver stiffness measurement. If it's more than 20%, it indicates improvement in terms of treatment. So if your liver stiffness measurement reduces, that's a good sign. If it goes below 8, it suggests that you have low risk of liver-related events. But if it increases and goes beyond 12 and 13, then the patient is already having fibrosis and patient is already having cirrhosis. And this patient are more likely to decompensate and develop complications. And these patients are generally not that well salvageable if your KPA values are very high. What about FIB4 index? FIB4 index is again a non-invasive blood test, right? We already had discussed what is FIB4 and everything. So you can do it every 6 months. Again, FIB4 interpretation, you already know, we already discussed, less than 1.3 is fine. Again, serial measurement of FIB4 is also useful. So instead of just doing a SGPT, SGOT and relying on just on SGPT, SGOT, a serial measurement of FIB4 can be useful as far as monitoring of patient is concerned. If the patient can afford an MRI, then you can do MRI PDFF to look at the changes in the fat percentage. You can do it annually, or you can consider doing a MR elastography, and you can do a iron corrected CT1 MRI also. That also looks at liver inflammation and fibrosis. So these are the various MRI modalities, but MRI modalities naturally will be more expensive and only in patients where fibroscan cannot be done for other reasons, like patient is super obese. Maybe MRI is useful, but most cases again a FIB4 index and fibroscan is more or less good enough for monitoring this patient. Of course, SGPT, SGOT, and all the things you'll monitor. But instead of what I suggest is a twist here. Instead of just doing SGPT, SGOT or a liver function test, you should do a FIB4 index, and that will give you a more accurate thing. You basically require platelets and require a calculator. Okay. So again, liver stiffness measurement more than 12 or FIB4 more than 2.6, you should definitely consider sending the patient, because patient already by definition would have cirrhosis, and then the patient requires care by a hepatologist. We already saw more than 20% reduction of liver stiffness measurement on a fibroscan is a good sign. And, again, other interventions should always be considered. And cardiovascular risk assessment and risk reduction is considered as a part of the treatment. Okay. So how frequently? Lower risk patients, you can, so generally 3 to 6 months is the usual follow-up time. High risk patients, we'll call them every 3 months. Intermediate about 6 months, and low risk patients can be called up annually, and that's where you can do the routine measurements on an annual follow-up. Okay, so let's now pull up some MCQs, and then we'll also take some questions. So this is end of part 1 of today's discussion, and let's pull up some MCQs and multiple choice questions, and also then look at some of the questions which you put in the comments. Okay, so these are the 2 MCQs we have for this part. A 48-year-old male patient with BMI of 33, metabolic syndrome, hypertension, has abnormal liver enzymes. His SGPT is 72, his SGOT is 58. The fibroscan shows a CAP value of 310. If you remember, 230, more than 230 was considered to be high. Liver stiffness more than 8 is considered to be high, so it is 9.8 in this patient. A liver biopsy confirms F2 fibrosis, so liver biopsy was also done. And its HbA1c 6.3, LDL is 155, which of the following represents the most appropriate comprehensive management for this patient. So lifestyle measure alone with reassessment at 1 year, lifestyle with statin therapy, statin therapy and consideration for medication, and immediate referral for bariatric surgery evaluation and vitamin E supplement. What would be the correct answer? You can just answer this. A lot of you are answering. Second question. 56-year-old woman with hypertension, dyslipidemia, again BMI of 33 is referred for MSLD. You can see her SGPT, SGOT, FIB4 score is 1.9. The VCT is a little high. The CAP value is also high. Liver biopsy confirmed again F2. Ask for what should be considered as a successful therapy. So which of the following represents a successful therapy? So reduction of BMI with resolution of hepatic steatohepatitis on ultrasound, is that successful? Would you consider liver stiffness measurement? So of course, all of them are good, but which is the best monitor? Achievement of 7 to 10% weight loss would be good, or would you consider normalization of lipid with LDL below 100? So yes, this is, I think, the question number 2 is a little bit controversial in the sense that, most answers are correct. All the answers are correct. But I think what would be the most appropriate in terms of the goal as far as the liver perspective is concerned? Yeah. So meanwhile, I'll allow you to answer while we'll take some questions from the chat. Dr. Jayesh Shah has raised his hand. So Dr. Jayesh Shah, you can put your question in the chat box. We'll discuss that. In the end, we'll allow all of you to talk. So Dr. Chandan Kumar has asked. Okay. I will just come back. So you can put your hands down. You can just put it in the Q&A section, and we'll take this up as we go along. And yeah, okay. So Chandan Kumar has said, in MSLD, what LDL cutoff should we follow to start statin? Should be given to all patients irrespective of LDL TG levels? Not to all patients, but the point is that just like in any metabolic syndrome or type 2 diabetes, your target should be to keep the LDL below 100, ideally below 70. So again, anybody with LDL more than 100 should be considered as a high risk, and treatment should be considered. I think the guidelines are same whether you are a diabetic or you are having MSLD with or without diabetes. Okay, so I think that's the answer. I think that's so the point answer, to just put it short, more than 100 LDL with MSLD, consider treatment. What is the role of metformin and pioglitazone? We'll discuss that we'll discuss metformin. We'll not discuss metformin because I think it's a very little role, but we'll discuss pioglitazone in this case. Dr. Jayesh has asked, if LDL is below 70, patient is on saroglitazar, diabetic, SGPT, SGOT are 4 times high, should statin be given? Yes. So the guidelines are saying that statin should be 4 times, should be meaning that, I'm assuming SGPT will be somewhere around 120s. Unless the patient has some other reason for you rule out all the other causes of hepatotoxicity, and the patient does not have any other reason for hepatotoxicity, statin, that is the guideline. That is what the current guidelines are saying. If you have ruled out other liver diseases and your patient has MSLD and only MSLD, and SGPT, SGOT are high because of MSLD alone, statin should be given. The benefit far outweigh any risk. Sometimes there could be transient increase of SGPT and SGOT also, but despite this, statin should be given because the benefit far outweighs the risk. Okay. Yes, rapid weight loss. What is harmful? You had asked me this, and let me answer this. So rapid weight loss of more than 1 kg per week, is considered to be harmful because again, it can potentially lead to gallbladder related issues, right? It can lead to gallstones, and it can so that's the reason why we should not target more than 1 kg per week of weight loss, right? So that's the target. Okay. Any direct benefit of salt restriction? Not directly in a sense, but yes, it's part of the treatment of DASH, diet and metabolic syndrome. Okay, no screen showing question. I think Sony, you probably have to look again. The polls and quizzes would have popped up in your Zoom. So I think there are already people have a lot of 65% have already answered. So probably it should be there on your screen. But the same question will also be there on the technochronology platform. So you can sign up and you'll find the question there. Saroglitazar should be prescribed. We'll talk about saroglitazar, Dr. Amit. Subranil has asked, what about prognostic fibroscan protocol? We had discussed fibroscan in the last talk in more detail. So you can go, and if you missed the last talk, you can go back to the talk on, it's there on Endocrinology India YouTube channel as well as on technochronology.com. Ravi has asked, role of liraglutide. We'll discuss this, Ravi. PIP4 fast app are downloadable on our mobile? No, they're not downloadable on the mobile. So, but basically you have to go to technochronology.com, sign up for the MSLD course. All that can be done via mobile. So for that, you'll have to download the app called Thinkific, right? You have to download the Thinkific app and then search for technochronology on Thinkific, and then sign up there. Okay. We'll discuss about Zubair has asked about levothyroxine. We'll discuss about levothyroxine. We'll discuss all these, right? Okay. Sony has said it's resolved. Good to hear. Dr. Garg has asked role of intermittent fasting in patients in both. Yes, so there is role, Dr. Garg, for intermittent fasting for both type 2 diabetes and MSLD as well. Like I said, we're not going to specifics. There are some very nice review articles on intermittent fasting from New England Journal of Medicine. Maybe we can have a separate discussion on diet separately because it's a complex topic. But intermittent fasting does have a role in both MSLD as well as type 2 diabetes. Yes, so that's the answer. So I think we can end the poll here. And just to give you the answers to the questions. So I think most of you answered correctly. The first question, the answer is C, which is perfectly correct, right? And that's the correct answer. And the second question, again, what we are looking. So I think second question, like I already said, was a little controversial. The correct answer is B, decrease in liver stiffness measurement. That should be the the thing we are looking for. All the other targets are also correct. So you're not completely wrong. Maybe somebody would argue that cardiovascular risk reduction should be the priority, but I agree. The point is that here, the answer we're looking for is that as far as the liver perspective is concerned, what you're looking for is reduction of the LSM or liver stiffness measurement on a fibroscan. Right. So let's then move to the next section, and that's the medications. So we discussed a little bit about lifestyle, and now let's discuss about medications. So medications, what I've done is I've divided it into two parts. One is the first part where we are going to discuss about the drugs which are approved for use in MSLD. And the second part we are going to discuss is we are going to discuss the drugs which are repurposed, so which are basically indicated for some other reason, and they have been now used in MSLD, right? So that's the part. I think it's taking a little longer to load. Give me 1 second. Okay, so what we're seeing now is what we're discussing now is the currently approved medications for MSLD. And then in the second part of the medications, we'll discuss the drugs which are not approved for MSLD, but can be used along with the comorbidities. Okay, so we'll discuss this. Right now, there are two drugs which are approved for MSLD. Right now, in the US FDA has approved, there is just one drug currently approved by the US FDA for MSLD, and that is called resmetirom. And there is only one drug approved for MSLD in India by the DCGI, and that is saroglitazar. So there are currently only two approved drugs specifically for the indication of MSLD. So your UTCA, vitamin E, OCT, liraglutide, all these are useful. We'll discuss that in second part, but they are not approved for, so you'll have to find another indication for the use of the same. So just keep that in mind. Purely for MSLD, only these two drugs have been approved by guidelines elsewhere. Now, let's first discuss about resmetirom. Resmetirom is the only drug approved by US FDA as of today for MSLD. What is resmetirom? Resmetirom is TR beta, thyroid receptor beta agonist. Now, we are going to discuss about the intrahepatic hypothyroidism in the next presentation. But the point here is the thyroid receptor. There are alpha receptors and beta receptors. The alpha receptor is present in the heart, and the beta receptor is present in the liver. Now, what you want is you want a drug which acts only on beta receptor without acting on alpha receptor, because acting on alpha receptor in a normal euthyroid patient can potentially lead to arrhythmias. So what you're doing is, what they've done is they've developed a drug which acts only on the beta receptor. And the drug here is the resmetirom. So it's a TR beta receptor agonist. Now, T3 helps in intrahepatic hypothyroidism. We'll discuss about T3 in a few minutes once again. So most of the data that you get about MSLD with treatment of resmetirom comes from this one particular trial. This particular trial was called the Maestro-NASH trial, the Maestro trial. The Maestro trial took older 18-year adult patients with 3 or more metabolic risk factors to define a metabolic syndrome. They did fibroscan of all these patients, and they included patients with CAP value more than 280 and liver stiffness measurement, the KPA value of more than 8.5. That is the criteria which they defined for the patient within the past 3 months. And alternatively, a liver biopsy was performed within 6 months after randomization to see if they are eligible based on the biopsy by the pathologist. So they did this fibroscan and biopsy, right? Now, they looked for histological evidence for NASH on the biopsy and an NFLD activity score of 4 or more, with score more than 1 for each component. That is, we discuss about the criteria for steatohepatitis, that is steatosis, lobular inflammation, hepatocellular ballooning. So if you had these features, the patient was included in the study. At least 50% of the enrollment were patients having fibrosis of F3 stage, right? And they took patients from F1B, F2, and F3 stages. Maximum patients they took with more than 50% required that the patient should be from F3 stage. And if you talk about F1, not more than 15% should be in the F1B stage, and no more than 3% having F1A or F1C stage, right? So basically what they're looking are slightly higher risk patients rather than baseline lower risk patients, right? So that, you get more response in terms of the patient should have weight stability. So should have less than 5% change in the weight and stable doses. So if they're taking a GLP-1, they should be on stable doses of GLP-1 for at least 6 months before the biopsy. Okay, so that is what they looked at as far as the criteria for enrollment was concerned. So these are the same type of patients you'll probably use when resmetirom is not available in India. Whenever it's available in India, it will probably never come. It's very expensive drug. If it does come in India, these are or maybe some variants of this will come in India in future. These are the things you have to keep in mind while selecting your patient. Okay, so what is F1B? Basically, F1B is portal fibrosis without septa. So they took F1B, F2, and F3 stages maximum of these patients. Now, did they all undergo biopsy? Yes. So this makes, so the good thing about this study is that they were taking patients with biopsy proven, MSLD with fibrosis or biopsy proven MASH. So they took patients, all underwent liver biopsy, and biopsy confirmed MASH, and they confirmed F1B, F2, or F3 stages of fibrosis. So this was the inclusion criteria, so biopsy was something which was important for these patients. So resmetirom was given in 2 doses, 80 milligram and 100 milligram, right? So this was what I looked at. And what are the endpoints they were looking at? So they looked at NASH resolution without worsening of fibrosis, and fibrosis improvement, right? So these are 2 primary endpoints, NASH resolution and improvement in fibrosis. And so what were the results of these primary endpoint? So what they found was both the doses, both 80 and 100 milligram, there was statistically significant. So you can see on the right side, the chart which is taken from New England Journal of Medicine. So they found, compared to placebo, they had 25% and 29%, 30% respectively reduction of, and which was statistically significant, NASH resolution. So almost 30% of the patient had NASH resolution with treatment with resmetirom, more with the 100 milligram dose. And the second endpoint was, if you see here, it was the reduction in improvement in fibrosis. And again, if you see, about 25% of the patient with both the doses actually have improvement in fibrosis. Okay, so there's fibrosis improvement also by at least 1 stage in these patients. And this is what again was seen in the study. So it's a good study, right? Very well conducted study, very rational study. And you can also see very good results, right? So there is actually improvement in fibrosis as well as there is improvement in the inflammation, the reduction of MASH also. The main side effects were mainly diarrhea and nausea, no major side effects as such which are known. They also looked at some secondary endpoints, and which is, I think, the very interesting part. And this makes resmetirom a potential drug for other conditions also. So the second endpoint they looked at 24 weeks was reduction in the LDL level, cholesterol levels. And some other secondary endpoints, they looked at ApoB reduction, triglyceride reduction, ApoA reduction, the MRI-PDFF score reduction, SGPT, SGOT level, and GGT levels. So what were the results of the secondary endpoints? So if you see LDL reduction, there was 13% to 16% reduction of LDL in resmetirom group, which is very interesting. So it does reduce LDL also, and hence indirectly would also reduce the risk of cardiovascular disease also. There was ApoB reduction also, which was seen. Triglyceride reduction also seen. ApoA levels at 24 weeks decreased significantly in resmetirom group. So this is very one drug is actually showing reduction of lipoprotein A levels also, which is very interesting. MRI PDFF also showed improvement, and SGPT, SGOT levels and GGT levels also significantly reduced. So these are all endpoints they looked at in these patients, and they found good reduction in these situations, right? So this is what makes resmetirom a very attractive drug, and that is the reason if unquestionable trial results, which makes this drug extremely lucrative and also makes it very extremely valuable for patients with MSLD, because you're actually reversing fibrosis with this group of drug, right? So this makes it a very good drug for patients with MSLD. What about saroglitazar? So in India, the only drug which is approved for use by DCGI for MSLD exclusively is saroglitazar, right? And saroglitazar, which is LIPAGLYN. What is saroglitazar and how does it act? So I think this is a question which a lot of you had asked, and this is the answer. So saroglitazar is available in the dose of 4 milligram. Only one dose you have to use, 4 milligram. Don't have to increase or don't have to reduce the dose. 4 milligram is the standard dose you have to use. It's a dual alpha and gamma agonist. Okay. So the alpha agonist activity, it is similar to fenofibrate, and gamma agonist activity is similar to pioglitazone, right? So it's an alpha and gamma. It's predominantly an alpha agonist compared to gamma agonist, right? So it's more of an alpha compared to gamma. Now, there are many glitazars which were under development earlier, but some of these, only one which actually stood the test of time, and that was LIPAGLYN. Okay. So both these conditions, both these situations leads to improvement in the non-alcoholic fatty liver disease and metabolic syndrome aspects. So originally the drug was developed for triglyceride reduction, but what they also found across the course of treatment that not only does it reduce the triglyceride quite significantly, but it also reduces the helps in MSLD and also helps as it works as an anti-diabetic also, and there is about 0.54 to 0.5% reduction of HbA1c also, right? So it reduces HbA1c as well, and that again, all this situation makes it a very attractive drug. It's a weight neutral drug, so it does not lead to weight loss. Okay, so it has a dual agonist action, and through its action, there are animal studies done where they looked at reduction of TNF alpha and IL-6 also. So it has inflammation reduction also. It also reduces steatosis and has anti-fibrotic property by downregulation of TGF beta also. So these are the actions which make saroglitazar a very attractive and, like I said, the only approved drug for MSLD exclusively in India. So if you have MSLD with diabetes, that's a different issue, or MSLD with obesity, it's a different issue. But if you have just MSLD, then the only drug approved is saroglitazar. Okay. Now, where does the clinical evidence for saroglitazar come? The evidence comes from these trials, right? So you have evidence 4 and evidences 4 and evidences 2. Evidences 4 was a phase 2 and evidences 2 was phase 3 trial. The phase 2 trial showed the reduction of the SGPT levels quite significantly compared to placebo. But they also looked at the MRI PDFF values, and they found that the MRI PDFF, there was 20% reduction of the liver fat content. For evidences 2, which is a phase 3 trial, they looked at the an NAFLD activity score, NASH, and they found NASH reduction of more than 2 points in these patients. Also, they took non-diabetic patient outcomes, and they did fibroscan in these patients, and they found that there's reduction of the LSM, the liver stiffness measurement, from a mean value of 11 to 8.5. So there's good reduction of LSM value. All of these are statistically significant, and CAP reduction of about 48 at 52 weeks of treatment, right? So this is what comes from the phase 3 trials, right? So the point being that it's a good drug. There is, however, and let me put a caveat here, most of this data comes from non-invasive parameters, and there are of course studies done for invasive. There are biopsy-related studies also there, but they are done in very small groups of patients. The major studies basically deal with the non-invasive parameters, and again, that is something which you use in clinical practice also. What about the other benefits? triglyceride reduction. There is 66.9% reduction of triglyceride. And, again, HbA1c reduction, we talked about 0.4 to 0.5%. In fact, in these trials, they were shown combined reduction of 0.59% HbA1c reduction, which makes it very similar to a DPP4 inhibitor as far as the HbA1c reduction is concerned. 21% reduction of LDL levels and 52% non-HDL cholesterol reduction also. So these are other extra benefit. Now, based on this entire data, the DCGI has given approval in 2020 for NAFLD with comorbidities. That's the indication given. Comorbidities mainly being metabolic syndrome, which of course, patients are going to have because the definition itself requires comorbidities. Dose is 4 milligram. Duration of treatment is 24 to 52 weeks based on fibroscan and MRI PDFF monitoring. And again, you have to remember, US stiffness measurement, reduction of more than 20% is what you're looking at. It is indicated for non-cirrhotic NASH and diabetic dyslipidemia as therapy for this group of patients. So this is the approval. As far as safety profile is concerned, generally does not have any major side effects. Few patients have pruritus, some have transient diarrhea. No hepatotoxicity known, no weight gain. It's a weight neutral drug. And it is also safe in compensated cirrhosis patients, but decompensated cirrhosis patient, it's not been studied. So do not, it's not approved for decompensated cirrhosis. Of course, we have some patients, we have a lot of patients on that, and there has been no issues. But decompensated cirrhosis, I don't think as far as the drug is concerned, there will be any benefit, right? So mainly you're looking at, patients with cirrhosis, but compensated cirrhosis, and above that, right? Generally, again, similar F2, F3 stages of fibrosis are what you're doing. So if you talk about summary, it's a dual agonist. It has regulatory approval. It is efficacious in reducing liver fat and NASH markers are reducing. You get extra benefit of HbA1c, triglyceride, and LDL reduction, and generally safe and well tolerated as a medication. So this finishes our part 2 of the lecture today. And again, I'll remind you, if you require fibroscan, talk to your Zydus representative, LIPAGLYN representative, and they'll be able to help you to arrange for a fibroscan in your local center, wherever you are practicing. Okay, so let's then run the poll and take a few questions from your side as well. Okay. So let's take this quiz number 2, poll number 4.2. So you have this patient, 52-year-old patient with fibroscan, obese patient, diabetic. Fibroscan shows CAP of 290, liver stiffness of 9.2, both of which are high. Liver biopsy confirms NASH with F2 fibrosis. After lifestyle measures fails to show improvement, to consider starting resmetirom. Which of the following is the most accurate regarding this therapeutic option? Does the drug primary involve hepatic lipogenesis reduction? Does the treatment be contraindicated due to high HbA1c? Does the drug work through selective TR beta activation in hepatocytes? Does the liver biopsy should be repeated every 6 months during treatment to monitor? So liver biopsy need not be repeated. They were done in clinical trials for purpose of clinical trials, but generally speaking, for routine cases, you don't need to repeat the liver biopsy. You can use non-invasive monitoring devices. Second question is 45-year-old male patient with type 2 diabetes, dyslipidemia, presents with persistent elevation of liver enzymes. Triglycerides are 580, HbA1c is 7.8, ALT is twice the upper limit of normal. Liver biopsy confirms non-cirrhotic NASH. After discussion of treatment options, you consider starting saroglitazar. Which of the following best describes the mechanism of action which the patient, right? So I think this we had discussed, and most of you should be able to get this question correct. Let's take some questions from the Q&A. So Chandan Kumar says, why saroglitazar is not approved for USA or elsewhere? Is it in process or getting rejected for any reason? So, okay, let me tell you this, Chandan Kumar. The story here is that saroglitazar was actually developed in India. So it's an Indian drug developed in India. So what happened was it was initially developed for triglyceride reduction. Back in the day when triglyceride reduction used to be an important aspect of treatment in these patients. But however, what they found was that there was some benefit they started seeing in clinical, in the post-marketing surveys about the reduction of SGPT, SGOT, which they then started exploring as a separate entity, and they found that it was useful in MSLD patient. Now, once they had this data, remember it's an Indian company. it's very, very expensive to do clinical trials in the US. So to get US FDA approval, you will require a US trial. And just like you require for DCGI approval, you require an Indian trial. So it's very expensive. So initially they did not pursue it in the US. However, now they are currently undergoing clinical trials in the US after they saw that resmetirom did get an approval. They are doing clinical trials in the US. So there are ongoing trials in the United States with certain organizations there, mainly research organizations. So these trials are ongoing and they've not yet applied for an approval. It's never been rejected. It's never been applied, right? And once I think probably when they do the clinical trial in the US, we'll be able to get a better answer as far as the approval there is concerned. Now, the trial they are doing in the US also includes liver biopsies, which they have somehow not done in India, right? So that's the point. Can we use fenofibrate pioglitazone combination? Yes, Zuhair, you can use fenofibrate and pioglitazone combination. In fact, pioglitazone we'll discuss. It's a very good drug for type 2 diabetic patients with MSLD. But remember, pioglitazone is not approved for non-diabetic patients, right? So would you give a non-diabetic patient pioglitazone? That's questionable. Also remember that, but LIPAGLYN is approved. Okay, so that's something you have to consider. Okay, so so you can, right? You're right. Go ahead. You can give this combination, but the criteria is that the patient should have indication for pioglitazone in the first place. Also, okay, what has not been seen? There is no increased risk of cardiovascular disease with PPR gamma, which has been known with pioglitazone worsening of heart failure, which has not been seen in. Of course, heart failure patients were not generally included in any of these trials. Having said that, there has been no, worsening of heart failure or new onset of heart failure because attributed to saroglitazar. So I think that again is a good point. Dr. Amit has asked if patient has grade 3 fibrosis but normal LSM score, should saroglitazar be prescribed? Dr. Amit, I think it's because of the strong correlation between fibrosis and the liver stiffness measurement. Generally, patient will have LSM score which is high, right? So probably then if it's not high, maybe the test was not done properly. So I'll probably consider repeating a fibroscan or maybe consider doing MR elastography. But it's very unlikely. But having said that, yes, if the patient has proven liver biopsy has proven grade 3 fibrosis, yes, you should consider giving saroglitazar. So again, fibrosis grade 2, grade 1, 2, 3, you should consider giving, right? Dr. Amit has also asked, if LSM is reduced by 20%, should treatment be stopped for 1 year? Okay, that's not very clear as far as, so saroglitazar, generally they're saying treatment for 24 to 52 weeks. That is what the approval from DCGI is concerned. But I think, yes, it will lead to improvement in the steatohepatitis. But again, that has to be backed by, so if the patient wants to remain free from MSLD, just like your diabetes remission, the patient has to then aggressively pursue lifestyle measures and prevent MSLD from developing again. So yes, you can consider stopping. Generally, 52 weeks, after 52 weeks, you can stop the drug. But yeah, yes, that should probably answer the question. Priyanka Chaturvedi has asked, what level of fatty liver or SGPT should you initiate? So Priyanka, again, what you have to consider is that you have to consider doing. So if you are treating just for MSLD, you have to consider doing either a FIB4 score, or you should consider doing the fibroscan. Okay, so if your FIB4 score is between 1.6, 1.3 to 2.6, you should consider backing that with a fibroscan. If it's more than 2.6, patient already has some amount of fibrosis. Generally, more than 2.6 would correlate with F3 fibrosis. So you can directly start, unless the patient is having decompensated cirrhosis. If the patient has, you can start saroglitazar. If the patient is between 1.3 to 2.6, you should consider doing a fibroscan. And if the fibroscan shows KPA value more than 8, then you should consider using saroglitazar for the point of view of the MSLD. But the treatment is not decided by SGPT, SGOT level. The treatment is decided by FIB4 score or the fibroscan. Okay. So I hope that answers your question. You have Zuhair. I think you already answered this. Wahid has asked, since saroglitazar helps in HbA1c reduction by improvement of insulin sensitivity, could it be used in pre-diabetics? Can it be used in pre-diabetics? It can be used, but it's not been approved, right? So there is no approval, but off-label you can, right? So we have used in pre-diabetic patients, but generally, again, very difficult to find pre-diabetic patient without MSLD these days. So in hepatic preparations can be given with saroglitazar, any contraindications? With which hepatic preparations? I mean, there's no other contraindication, so you can give any other drug with saroglitazar, so it should be. How long should medications be used? 52 weeks as far as saroglitazar is concerned. And resmetirom, again, there is no upper limit to what time you can give. But again, most of these trials have been done for 52 weeks and they have shown improvement up to that period of time. Rajkamal, age limit for saroglitazar, I think there's no age limit. Adults it can be used in adults. There is no upper limit of age. Just do not use it in decompensated cirrhosis. Other patients you can use. Dr. Garg has asked, sir, there are 2 more drugs for trials, so we'll discuss the other drugs. Yes. Okay. Amit has said, sorry, I meant grade 3 steatosis, normal LSM score, normal FIB4 score, you're saying. Grade 2, okay, got it. So with steatosis, but normal, yes. So you can use it just for steatosis also. So you do not have fibrosis. Fibrosis, of course, you'll get more benefit, but just with steatosis also you can give saroglitazar. Yes. So I get your point now. Which patients need lifelong saroglitazar? No patients require lifelong saroglitazar as long as if they have reversal of their steatosis and they are able to maintain the lifestyle measures, they don't require saroglitazar lifelong. What we need to do is, you need to reinforce the lifestyle measure, right, along with the treatment. So the treatment is not just medication, it's medication with lifestyle measure. Yeah. Dr. Shekhar has asked, does the effect last after stopping saroglitazar after 2 weeks week treatment? What we are doing is, just to clarify, we are reducing, so patient has MASH or patient has fibrosis. You're using these drugs to reduce the MASH and fibrosis, right? To reverse the MASH and fibrosis. What about, does it improve steatosis? Yes, so improve steatosis also. But does it mean that the patient will not develop it again? No, does not mean that. Okay, so there are no residual benefits. The residual benefits come from lifestyle measures, right? I hope that point is clear. So, yeah. Raj Kamal has asked, what about pediatric patient? I think that's a separate topic. So, we'll not get into that. There are currently no approved drugs in pediatric group, except probably off-label use of liraglutide. But otherwise, there are no approved drugs. So I think we have to go with lifestyle measures. Can we use it alcoholic CLD after alcohol? Good question. It's not been approved for alcoholic chronic liver disease. So there are, of course, ongoing trials for resmetirom for alcoholic liver disease, but currently it's not been approved. Can you use it in MetALD? Yes, you can use it in MetALD. So that is metabolic syndrome with or MSLD with alcoholic liver disease combination you can use. But just for alcoholic liver disease, it's not approved. Whether you can use it off-label or not, you can. But again, whether it's going to benefit just for a pure alcoholic liver disease without metabolic issue, I am not very sure. We don't have data for that. Patient has metabolic syndrome and alcoholic liver disease, you can use it, right? So yeah. Okay, so I think that ends some of the questions. I think most of you got the correct answer for these questions. So I am quickly going through the third presentation. You can keep putting your questions in the Q&A section, and when we'll discuss that as we go along. Okay. Now let's take the third part, and that is reusing existing drugs for management of MSLD. Generally, in this case, we are going to discuss patient having certain comorbidities, like already having diabetes or already having hypothyroidism. Right? So these are the things we'll be discussing in this presentation. Okay, so these are the drugs that we'll cover in this part: SGLT2 inhibitors, GLP-1, and T3. Okay, and we have one more part after this where we'll discuss vitamin E and all those UDC and all that. Okay. So here we are mainly going to discuss some drugs which have some evidence as far as MSLD is concerned. Okay, let's discuss SGLT2 inhibitor. So what you have to understand here is, and this is a very important philosophical aspect I'm going to tell you, right? And a treatment philosophy aspect. I think we discussed this in the very first presentation also. So what I believe is that all these diseases have a common soil, and the common soil is ectopic fat. Okay, so the main problem is ectopic fat. Now, when the ectopic fat gets deposited in the liver, you have MSLD and you have central insulin resistance. You have excessive amount of fat in the adipocytes that leads to peripheral insulin resistance. Again, you have excessive amount of fat in the muscles that also leads to peripheral insulin resistance. You have excessive fat in the pancreas. You have what is known as fatty pancreatic disease that leads to beta cell dysfunction. So when you have a combination of excessive fat in the pancreas leading to beta cell dysfunction, central insulin resistance, and peripheral insulin resistance. Combination of all these things leads to type 2 diabetes. Then you have fat deposited in the epicardial region that leads to heart failure or HFpEF. And then you have fat in the renal sinus that leads to renal dysfunction. You have fat in the ovaries and the peri-ovarian region, which leads to PCOS. Right. So, and you have, so all these things in combination ultimately is what is known as adipositive. Everything is combined. And some of these drugs, especially 3 drugs, SGLT2, pioglitazone, and GLP, have benefit in all 3. Now, of these 2, SGLT2 and GLP-1RA actually directly reduce the fat, right? So SGLT2 inhibitors reduce the fat from all these areas. So they reduce the fat from the pancreas, they reduce the fat from the liver, they reduce the fat spillage from the adipocytes, they reduce the muscle fat, and they reduce the epicardial fat. So they reduce all these fats. And by reduction of all these fats, they have improvement in diabetes, improvement in renal dysfunction, improvement in MSLD, improvement in cardiac function. Same thing happens with GLP-1RA, right? So all these drugs act in a similar way. Pioglitazone acts in a different way. What pioglitazone does is, so remember, the problem with adipocytes is that if you have a fixed number of adipocytes and you are being packed into these adipocytes, this is ultimately what leads to inflammation in the adipocytes and spillage of the fat from the adipocytes. Now, what pioglitazone does is, pioglitazone increases the number of adipocytes. So the common analogy that I often give is that, let's say you have some movers and packers who want to pack your house and want to help you move. So let's say you call some movers and packers, and what you have is they bring about, let's say, 5 boxes, right? So, or let's say 6 boxes they bring. Okay, so they bring 6 boxes, and तुम्हारे पास सामान है which is enough, right? More than enough for the 6 boxes. So they try to stuff all this saman in the 6 boxes, but the saman is excess, right? So what will happen is, while carrying, there are very good chances that the saman which is there in your boxes will start spilling. So this is what typically happens in all metabolic diseases, right? You have more amount of fat than the adipocytes can take. Now there are 2 things you can do: either reduce the saman or reduce the fat, which is what SGLT2 and GLP-1RA do. Or secondly, what you can do is you can increase the number of boxes. So ask your movers and packers to bring 6 more boxes. So then what they will do is they'll distribute the saman, distribute all the stuff you have in the 6 boxes. So if they distribute all the stuff in the 6 boxes, the boxes are evenly spread out and the chances of spillage are less. So pioglitazone, what it does is it increases the number of adipocytes. And by increasing the number of adipocytes, it redistributes the fats amongst the adipocytes, hence not causing spillage of the fat from the adipocytes. So that is how pioglitazone acts. And the other way is where SGLT2 and GLP-1RA act. So SGLT2 typically melts the fat from all these areas, and hence it is beneficial in MSLD also. Now, where does the evidence generally come from, right? So there is now several studies which have looked at in fact, all the 3 major SGLT2 inhibitors, that is the EMPA, the DEPA, and the CANA, and all the 3 have shown independently in different studies benefits as far as MSLD is concerned. So they found liver fat reduction using MRI. They found improvement in SGPT, SGOT. They have found improvement in the surrogate markers for fibrosis. They've seen some existing benefits for a prolonged period of time, and they found that all these things are beneficial more compared to TPP4 or sulfonylurea, right? So all these benefits are seen with SGLT2 inhibitors across the board. But there are reasons why its use is still not widespread in this situation, because none of these studies are biopsy proven. None of these are biopsy proven. They are all based on surrogate markers. Also, most of these studies are done in diabetic patients, and we do not have data in non-diabetic patients. So what you need to do is, if you want to say that it helps in MSLD, you need to do specifically the trials in non-diabetic patients, and you need to do biopsy proven trials, and you need to do trials very similar to what these people have done with resmetirom, right? So that is what needs to be done specifically if you want to say that SGLT2 can be used independently in MSLD without diabetes, just for MSLD indication. Also remember, at this point of time, we don't know whether the benefit really comes from weight loss or the benefit is beyond the weight loss. But generally speaking, the weight loss with SGLT2 is not extreme. Certain patients have extreme weight loss, But most patients, generally the weight loss and the benefit of 2 to 3 kgs, which is not enough to reduce so the benefit actually comes from beyond weight loss, right? And that is what certain studies where they've looked at SGLT2 specifically, particularly a study done called eLIFT study from India, which has actually shown that the benefit goes beyond just weight loss. There is actual pathological benefit that comes from SGLT2 inhibitors. And in my opinion, expert opinion, SGLT2 inhibitor is a very good drug that should be considered in patients with type 2 diabetes and MSLD. Okay, so current position, benefit does extend beyond weight loss. It's a complementary mechanism of action. It has sustained benefit in some observation studies, mainly observational. We don't have dedicated trials for this. Again, there are, of course, cardiovascular benefits and renal benefits, which you all know. However, it's not specifically been approved for MSLD. Okay, so of course, in futures, you will have more studies. If that does happen, then you might be getting more data from that. Okay, now the study which really looked at MSLD from a perspective of SGLT inhibitors, specifically empagliflozin, was a trial which was done in India called the eLIFT study. This eLIFT study was done in Medanta, and the chief investigator was Dr. Shafi, who is an endocrinologist from Medanta. Very well conducted study. Actually got a center stage at American Diabetes Association (ADA) meeting. I was present at that meeting. I think it's a great achievement. I really feel that this achievement has not been getting the due recognition which it should be getting. Okay, having said that, let's talk about the trial, the eLIFT study done by Dr. Shafi. It was a study which looked at SGLT2 effect on liver fat. I've given the full trial data on the technology website. This is just a glimpse of it. So they looked at effect of empagliflozin on liver fat, and they mainly used MRI-PDFF for this purpose. It was a 20-week open-label trial which looked at 50 patients. So of course, number of is also small. They took empagliflozin 10 milligram versus standard diabetes treatment. They took diabetic patients. They looked at the primary outcome, that is the empagliflozin liver fat reduction. So MRI-PDFF improvement, that is what they looked at. They looked at the ALT levels also. So these are other secondary outcome, and AST levels also, and GGT levels. They looked at, of course, the glycemic parameters and looked at the safety profile. And what they found was the MRI-PDFF reduction was statistically significant, right? 16% versus 11% in placebo group or the control arm. They also found the SGPT reduction, which was also statistically significant. SGOT reduction was present, but not statistically significant. And GGT reduction also was not statistically significant, but there was SGPT reduction, which was statistically significant. There were, of course, glycemic benefit, which we all expect and generally considered to be safe, right? So this is what they saw from the eLIFT study. You can see the picture here, right? Control versus empagliflozin as far as the baseline versus the post-baseline value. And this is what we're looking at is the MRI-PDFF values. And you can see statistically significant reduction of the liver fat using MRI. Again, this is not a biopsy-proven study. So it was a study done with MRI-PDFF and not with biopsy. Okay, so please keep that in mind. What about GLP-1RA? Now, the next drug after resmetirom, which is very close to getting an approval from US FDA for MRI, for MSLD, is going to be tirzepatide. It is very close to it because of one particular trial. I'll discuss this. Now, GLP-1RA, you find weight loss, which has benefit. There is direct benefit also. There is liver fat reduction also directly seen. And of course, it improves insulin sensitivity. So that is how typically it would act. We already discussed how it acts. So there is, of course, weight loss, which is helping, but there are direct effects also of GLP-1RA as far as the liver is concerned. Let's discuss the various drugs in specific. So you have the semaglutide trial, which was done. Okay, so it's not Mastronash. I'm sorry, the name is incorrect. So you had semaglutide, which they looked at semaglutide as far as the the specifically with NASH is concerned. They used 0.4 milligram of semaglutide. So they found that there was dose-dependent reduction with liver enzymes, but there was no improvement in fibrosis. So that is what made it a problem, right? So the semaglutide trial, which was done for MSLD, they found that they had a fat reduction, liver enzyme reduction, but no reduction in the fibrosis. But the trial which actually was which it was amazing, was the tirzepatide trial, which was the Synergy NASH trial. It was specifically done for this purpose. even with the Surplus-3 trial, which was a trial specifically for other reasons for tirzepatide, you can see on the picture the baseline versus reduction of the MRI. And if you see, this is a CT1 MRI, you can see the fat reduction, the liver fat content reduction in this picture, right? So you can see baseline it was 27%, and 52 weeks there was 2.6% reduction, 2.6% fat only. So significant reduction of the liver fat. So tirzepatide in the Synergy NASH trial, they found benefit in both diabetic as well as non-diabetic patient as far as the liver fat and fibrosis reduction is concerned. So in this study, they actually found significant liver fat reduction, glycemic benefit, weight loss benefit, and cardiovascular benefit also, right? So the study, this was phase 2 trial. They'll of course be doing more trials of this. We looked at MSLD in liver disease. So they found there was significant reduction of MASH resolution without worsening of fibrosis. Again, they did liver biopsies here. More than half of the patients experienced improvement in liver fibrosis, and then there are a lot of patients who actually found other benefits also, weight loss and other things. Okay, so this is the Synergy NASH trial. You can see here another picture where they looked at the liver fat reduction with this trial. Okay, so of course, there are other benefits: glycemic control improvement, liver enzyme improvement, and so on. So, right. So, however, despite all these trials, currently tirzepatide, Eli Lilly has not asked for an approval. I think they are in the process. So I am sure probably in future tirzepatide will get a US FDA approval for MSLD, or maybe some GLP-1 will for sure. The reason is that now the new generation GLP or the dual agonist is actually showing benefits as far as the the fibrosis is concerned. So I think one of the major things with semaglutide is that it did not show benefit in fibrosis, whereas the tirzepatide is showing benefit as far as fibrosis is concerned, right? So currently, it is not approved, but it's not that far away that you'll probably get approval. So tirzepatide should be definitely considered, or in fact, semaglutide should be considered for diabetic patients or obese patients, but for MSLD alone, it is not approved. But if you have diabetes with MSLD, you should definitely consider it. What about pioglitazone? I already told you how it acts in this situation, right? Again, similar benefits you get, some of them with the PPR gamma action via saroglitazar also. Saroglitazar, you have additional benefit. You can use it in non-diabetic patients also. You can use it in heart failure patients also. There is no contraindication for heart failure, whereas pioglitazone you cannot. Also, it does not produce weight gain. Pioglitazone produces weight gain, whereas saroglitazar is weight neutral. So you have some benefits of pioglitazone with saroglitazar, and hence without some of the side effects, which makes it an attractive option. But as far as pioglitazone itself is concerned, there are several trials which have shown improvement in hepatic steatosis, reduction of fibrosis, and prevention and regression of fibrosis, and reduction of NASH. In fact, there are biopsy-proven trials also where pioglitazone has shown all these benefits in biopsies, right? Of course, there are limitations of using pioglitazone. There used to be once a concern about bladder cancer, which is, I think, more or less now not proven. But you have weight gain, which is again problematic. You have risk of bone fractures, you have risk of heart failure also. So all these things makes it, though a good option, you have to be very cautious in patient. And remember, this is only for type 2 diabetic patients. So you cannot use it in non-diabetic patient, right? So it has a unique position. It is the longest studied agent for MSLD with type 2 diabetes. It was the only drug before tirzepatide. So again, sorry, before tirzepatide came, you had the only type 2 diabetic drug which had shown. So if you don't consider saroglitazar as a type 2 diabetic, so let's say, among type 2 diabetic drugs, there's only one which has shown fibrosis progression prevention. Remember, even SGLT2 did not show fibrosis prevention. They mainly are also showing liver fat reduction. It has been proven in biopsy-proven MASH with type 2 diabetes. It is recommended by guidelines, so it should be used. So if you have type 2 diabetes, but again, there are concerns, other concerns, which we already know. So pioglitazone should be strongly considered in type 2 diabetes with MSLD unless there are contraindications to it. What about T3 or T4, right? So we discussed this earlier as well. So I'm reiterating this point, and this also helps us understand. Also helps us understand how as far as resveratrol acts. So T3 is a hormone, which is the thyroid hormone. Now T3 individually is available in India. The very point that I'm discussing this is because we don't have resveratrol available in India, but you have T3 available in India. Okay, so we talked about the TSH receptor, the thyroid hormone receptors. The thyroid hormone receptors alpha, and so it's not TSH receptor. Just pardon me. I think we had the same mistake in the earlier slide also. It's TR receptor. It's thyroid hormone receptor, alpha and beta. The thyroid hormone receptor alpha is present in the heart, beta is present in the liver. Now, what is important is that subclinical hypothyroidism and overt hypothyroidism, both groups of patients have higher risk of having MSLD. So if you are untreated hypothyroid, you already have MSLD. And from this, now we have started understanding that there is something between liver and as far as the thyroid axis is concerned. So what they found was, there's actually a study where they looked at euthyroid MFLD patient and they actually used T4 or T3 therapy, or generally T4 therapy in euthyroid patients. This is one small study. And they actually looked that there was improvement as far as, we had discussed this earlier, there's some improvement as far as the MSLD is concerned. So if you talk about T4, there's actually one study which looked at specifically using T4 for euthyroid. We're not talking about hypothyroid. Hypothyroid patient, you're definitely going to treat. Euthyroid patient with MSLD, they actually found that there was some benefit with the use of this drug. Again, these are not biopsy proven. And the problem with T4 or T3 therapy for that matter is that long-term effect in euthyroid patient as far as cardiac and the TR receptor alpha activation is concerned is not known. Now, the principle here is this, and this is what we had discussed earlier also. So, and that's why probably T4 is not a good idea. T3 is a better idea. And this is where it really comes to this. So what happens is that you have the deoxygenase, deiodinase, which converts T4 to T3. So you have type 1 deiodinase, which converts T4 to T3. And you have type 3 deiodinase, which converts T4 to reverse T3. Now, the T4 to T3 conversions, the type 1 deiodinase is present in hepatocytes, whereas the stromal cells have type 3 deiodinase. Now, what happens when you have hepatotoxicity? The hepatocytes are reduced in number, so you have less number of hepatocytes. You have less number of hepatocytes, so what happens? There is less amount of T4 to activation to T3. And what T3 does is, T3 actually reduces intrahepatic fat. So this sets up a vicious cycle. You have more intrahepatic fat, more hepatic damage, less T3 activation in the liver, hence more hepatic accumulation of the hepatic fat. So this leads to a vicious cycle. So in these cases, theoretically, if you consider giving T3, what will happen is this vicious cycle will break. You have reduction of intrahepatic fat because you're directly giving T3 from outside. So ideally, T3 therapy should help in MSLD. But the problem with giving naked T3 therapy is that T3 will also act on the heart, especially if you're a euthyroid patient. It will act on the heart, and long-term effect of that on cardiovascular disease is not known. In fact, there is a risk of potentially having increased risk of arrhythmia in future. So that is what makes T3, though attractive, not a viable option for euthyroid patient. However, resmetirom is a good option because it only acts on TR beta, which is only present in liver. It is not present in heart, and hence a selective agonist is something which has been developed. Right? So this is something you have to keep in mind. And this is where this argument of mine always comes into picture. What I believe is that if you have subclinical hypothyroidism, so if you have TSH more than 10, anyways, you're going to treat with subclinical hypothyroidism. Subclinical hypothyroidism is when your TSH high, but T3, T4 are normal. So if you have TSH, which is already high, we are anyways going to treat subclinical hypothyroidism. But if it is between 4.2 to 10, generally we consider anti-TPO antibody. I think a better marker is to look at liver. Look at the patient's FIB4 score. Look at the patient's dyslipidemia. Look at the patient's presence of MSLD. If you have this and subclinical hypothyroidism, my recommendation is you should consider treating. Remember, it is not euthyroid patient. Instead of anti-TPO antibody, and I very strongly dislike anti-TPO, it's a very non-specific antibody, does not give you any information. It's a badly done test. I believe the better test is actually to look at the liver, because end of the day, you're treating the patient to help them in a long-term benefit point of view. So I think if you have a subclinical hypothyroidism and the argument is to whether treat or not, I think what you should be looking at is the FIB4 score and MSLD instead of looking at the anti-TPO and other things. And if the patient is already having some amount of evidence of MASH or fibrosis, then possibly you should consider treating this patient. And in that argument also, I would say probably you should consider T3 in preference to T4 in terms of treatment. Right. So this is my whole argument. Again, this is an expert opinion. I don't have any clinical study to back this. This is just a expert theory which I'm giving, right? So to give a take-home message, if you have subclinical or overt hypothyroidism with liver involvement, with fibrosis, or with evidence of MASH, probably you should consider giving T3 also, apart from T4, in terms of treatment therapy. And subclinical hypothyroidism, from a liver perspective, definitely should be considered for treatment. Again, caveat, expert opinion. Okay, so this is the thing. Let's now look at a couple of multiple choice questions, and this is end of part 2. And we'll also take your MCQs, your questions, which will be there. Let's just run this board. Okay. So 52-year-old patient with type 2 diabetes, HbA1c is 8.2, similar type of pictures, right? So already on metformin. And you can see MRI PDFF shows liver fat, right? He has no history of alcohol use. Which drug would you add additionally, right? So remember, this is an obese patient. Okay. So which drug you'll add? Second question is, which of the following is the most appropriate treatment addition? Second question, 48-year-old female with HbA1c of 7.4, BMI, she's lean, SGPT, SGOT are high, abdomen shows hepatic steatosis. Which of the following is the most appropriate drug you can consider adding? Third question, 45-year-old female with persistent fatigue, unexplained diseases, BMI 31, is having TSH of 6.8, SGPT, SGOT are high, abdominal ultrasound shows steatosis. Which of the following is the best treatment for this? Okay. Okay, so this yeah. So I think very easy questions, I think. So let's look at some Q&A. So Dr. Amit has asked, in patients age 65 or more, fibroscan is not reliable in such patients. So yeah, I think probably, yes, Dr. Amit, you're right. Fibroscan is less reliable in older patients. Should you consider treating this patient? I think, again, what you have to see is, you have to then see the risk versus benefit in such patients. And what you have to see is, again, even fibroscan is not very reliable in older patients. So what you have to see is, remember, will they live long enough to develop cirrhosis, full-blown cirrhosis and decompensated cirrhosis? That is what you have to look at. And then you have to take a judgment call on whether to treat or not. So I think it's no easy answer there. Elderly patient with MSLD, what will you do? I think it's not easier. There are now certain variations of FIB4 where they are using it for older patients also. So you can use that. But I think, yeah, so I would say that as an answer. Chandan Kumar, yes, metformin. So metformin is controversial. Okay, now let me tell you about metformin. See, metformin has always been thought that it should reduce, it should help in MSLD, but there is several trials and none of the trials have shown any benefit of metformin as far as MSLD is concerned. So right now, we don't have any evidence for, right? Even the weight loss with metformin is very modest. So it does reduce SGPT, SGOT, but does it really reduce liver fat or reduce fibrosis? Answer, we don't know. And most clinical trials, that is, what is the small studies that have been done, have not shown benefit. So I would say, see, anyways, type 2 diabetic or pre-diabetic patients, there are indications for metformin. So there's no harm in giving metformin. But as far as liver is concerned, don't just rely on metformin. The point is just don't rely on metformin alone. Consider other treatment also. That's the thing. Sony has said pioglitazone is weight. It is not weight neutral. It increases the weight. I was talking about saroglitazar, which is weight neutral. So saroglitazar is weight neutral. Pioglitazone increases the weight. Okay, Abhinav has asked, I would like to take your opinion on my reports. I'm 35-year-old type 2 diabetic with familiar hypertriglyceridemia, BP is controlled, HbA1c is 5.7, intolerance to SGLT2, was on Roseday EZ, Phenolip, LIPAGLYN, lost 13 kgs through one meal diet, but TG is now 680, refuses to come down. Apart from niacin and hot flashes, what can I take? The answer is omega-3 fatty acid. What you should take is omega-3 fatty acid. You have icosapentol now available in India. It's available as ICOS. Sorry for saying the brand name, but yes. So you can use that, right? That answers your personal health question. Jayesh Shah has asked, what percentage of patients develop sarcopenia because of weight loss medication, loss of muscle mass is seen in? Yes. So that's a contentious issue. Dr. Jayesh, I completely agree. There is a bone of contention as far as, pun intended, bone of contention as far as sarcopenia is concerned. The problem, however, is the interesting thing is what studies have shown and now increasingly being looked at is that there is actually no loss of muscle mass, especially with GLP-1. You have reduction of fat mass from the muscle. So you have muscle fat which is reduced, but muscle fibers and muscle mass themselves are not reduced. So that is what some of these trials are now showing, and some of the studies which are being done, especially with GLP. However, I'm not 100% sure the same about SGLT2. I definitely feel that SGLT2 does lead to muscle mass loss also. So I think again you have to see the risk versus benefit. No simple answer, but I'll say of the two, I would probably trust GLP more than SGLT2 as far as preservation of muscle mass is concerned. Yes, you're welcome, Abhinav. Dr. Chirag has asked, non-diabetic patient with MSLD, can we give Rybelsus 3 milligram? Okay, just to complete the list, Rybelsus, the semaglutide which has been studied MSLD is not Rybelsus, it is Ozempic. So injectable semaglutide once weekly has been studied. Rybelsus has not been studied in MSLD. Can you give it? Yes, it will lead to weight loss and hence benefit your patient, but it will be off-label. So you can give it, right? That's the answer, but off-label. At what level of steatosis with F0, F1 fibrosis? So again, you can give it to any patient with hepatic steatosis as far as the guidelines are concerned, and as far as the approval is concerned. So you have objectively detected fatty liver in ultrasound, grade 1, grade 2, whatever. In that situation, directly you can start. Then, however, the benefit comes, the question comes is that, is it going to, if the patient does not have MASH or does not have fibrosis, then what are you actually treating? Just by reducing fat, does it really help? That's a difficult question to answer. Not all patients with fatty liver progress to develop MASH, and not all of them progresses to develop liver fibrosis. So only 30% progress. So 70% you will be unnecessarily treating. So that is the risk versus benefit you have to see. If there are other reasons to give saroglitazar, give it. Just for liver fat, questionable. But if you've proven that the patient has steatohepatitis, definitely give. If you've proven that the patient has fibrosis, definitely give. Right? I hope that answers the question. Yes. So I think that is what we looked at. And I think I can end the poll here. Share the results. We are already way behind time. But it's okay. I think as long as we're learning, we'll just quickly take the last presentation. And yeah, so I think most of you have answered it correctly. You can see the answers screen maybe, and then. Okay, let's look at the other drugs and other treatment options. So let's first talk about bariatric surgery. Okay. So what is the role of bariatric surgery? Again, if there is an indication for bariatric surgery, you can definitely consider. Bariatric surgery has been shown to improve the liver histology also. 88% improvement in the hepatic steatosis. Steatohepatitis, 59% reduction of steatohepatitis, and liver fibrosis also, it shows improvement, 30%. So there is definitely benefit as far as bariatric surgery. Only one caveat, only one. Do not do bariatric surgery in decompensated cirrhosis. Decompensated cirrhosis, it is contraindicated, right? So don't do it. Other cases you can. Even in compensated cirrhosis, there are some people who believe that it can lead to decompensation. So you have to be careful. But earlier grades, you can do it. Steatohepatitis, you can do it. Earlier grades of fibrosis, F2 fibrosis, you can do it. Cirrhosis, be careful. Decompensated cirrhosis, definitely no. Okay, so be careful about bariatric surgeries there. What about ruined by gastric bypass? Is the obviously the more weight loss, the better benefit you have. Then you have this newer class of drug, and this is Dr. Garg had asked this question. FGF21 agonist. So this is an emerging class of drug. So FGF21 is a metabolic switch. And if you remember our first lecture, we had discussed about FGF21 a little bit. So FGF21 patients, so when you switch on FGF21, it's an important metabolic regulator. So you can see here in this image what FGF21 really does. Okay, so by whatever means, and here also, Chandan had asked about metformin. Actually, metformin also probably acts by FGF21 also. So there is some benefit there as far as action, but mainly now you have dedicated FGF21 agonists which are being developed. So FGF21, right, when it's activated by whatever mechanisms, it leads to improvement in, it reduces lipotoxicity and reduces insulin resistance, hepatic insulin resistance. Also, it has actions on adipocytes, where again, it reduces the spillage of and lipolysis in the adipocytes and hence prevents the spillage of the fat from the adipocytes. And on the muscle also, it improves glucose uptake and reduces insulin resistance. So basically, FGF21 activation reduces insulin resistance and reduces liver fat. So that is what ultimately it is. Now, there is a phase 2 trial which looked at a FGF21 agonist for this, and they actually found improvement in both fat reduction as well as fibrosis reduction also. So there was benefit in both the situations. The trial is known as ND1 trial. So ND1 trial, there was 26% in the, so the drug which was used was pegozafermin. So pegozafermin is a long-acting FGF21 analog. They took patients with F2, F3 fibrosis. There's 26% reduction of, F1 with the 30 milligram group, 23% reduction of resolution of NASH without worsening of fibrosis. And of course, there are other liver fat improvement and content improvement also. So it's a phase 2 trial. However, again, it's still they're not applied for approval, but in future, definitely this is a drug, this is probably the next drug which will get approval as far as the, maybe tirzepatide or this, maybe one of these drugs, but currently it's still in clinical trial and unlikely to come in India anytime soon. So I think we can not worry about it much now. It's a theoretical concept and probably should keep that in mind. What about UDCA? UDLIV, right? UDLIV, very popular drug for MSLD. Does it have evidence? Right? Let me be very careful here. It's a little double-edged sword. Okay. So there are some benefits. So SGPT, SGOT reduction are seen. GGT reduction is seen, right? And generally the benefits are noted in the first 3 months of therapy as far as UDLIV or UDCA is concerned. But does it improve liver histology? There are some small studies where it's shown improvement in hepatic steatosis, but generally there are no significant benefit, no benefit on necroinflammation or steatohepatitis or fibrosis. So basically what you're seeing is, we are just seeing a superficial improvement. Does it really improve the liver pathology? That is not known. In fact, it is controversial, right? However, there's one study which looked at UDCA combined with vitamin E. And they found that combination therapy also had some benefit as far as the, the liver histology is concerned. So probably, again, we need more trials to look at this as a combination therapy. But currently, UDCA does not show benefit as far as liver pathology is concerned. It's a safe drug, not many side effects, so it's otherwise okay. So the use of UDCA in MSLD per se is controversial. I don't recommend it, right? I don't see any reason to just, window wash or just, superficially quote. There are better drugs available. Why not use them, right? So there are some studies which have shown some benefit, but generally, as far as liver histology benefits are concerned, it is generally not seen. So it is a debatable thing, right? Then you have obeticholic acid, right? The OCA. Now, if you remember, we had shown you FXR, right? Which is basically the farsenoid X receptor. This is a metabolic switch. You can go back to our first lecture. We had discussed FXR in detail. This OCA is basically an agonist of this FXR, right? So theoretically, again, it was probably thought that it should be good. Interestingly, it had shown some benefit as far as the fibrosis reduction is also concerned. And based on this, they actually asked for an approval from US FDA. But US FDA actually rejected its claim. Unfortunately, OCA did not get approval. Now, it's not very clear of the reasons. If somebody is aware, please, put it in the chat. Maybe I'm not exactly aware why it got rejected. But sometimes, FDAs can be very, controversial. So that is one of the reasons why it got. It's available in India. Whether to use it or not, I would say if you don't have any other option, maybe again because you have other drugs available, maybe you should consider using them. There are other side effects. Pruritus is a side effect. One of the major concerns is increase in LDL. That is also one of the reasons probably where FDA kind of thought, right? And there are some rare cases of hepatic decomposition and deaths with primary biliary. In fact, it's been used in primary biliary cholangitis. But certain cases there was worsening, whether again attributed to this drug, not known. But it For safety reasons also, it is not very well known. It's used in PBC, where it's used in 5 to 10 milligram dose. For NASH or MASH, 10 to 25 milligram is the dose. So it's still considered an investigational therapy. It has shown some promise, but whether risk versus benefit is good is not very well known. Somebody asked about glutathione last time. Again, very early trials have been done. Some benefit, early clinical trials, but again, whether it's an antioxidant. So again, reduces the hepatic beta oxidation in the liver, which again, if you remember our mechanism, we should discuss in the first lecture, it definitely should have benefit from a theoretical perspective. Whether it really translates into clinical benefit, there have been 300 milligram used in pilot studies. So mainly pilot studies, but again, we don't know much about it as far as the current medication is concerned. It does improve liver function, reduce inflammation, but there could be, individual response. Again, we don't have long-term study of its safety also. So it's a controversial use case again. One drug which has been around and had stood the test of time is vitamin E. So vitamin E, the data for MSLD comes from PIVEN study, which was a landmark study which was published in New England Journal of Medicine 2010. Now, what you have to understand is vitamin E can be given for MSLD without diabetes. So non-diabetic MSLD patients, it has been shown to benefit specifically in this clinical trial. So this was a RCT where they looked at patients, non-diabetic patients with MASH, and they gave vitamin E 800 international units. There was also the same trial used pioglitazone, and the PIVEN trial also showed benefit for pioglitazone independently. In diabetic group they used, and the duration of therapy was 96 weeks. So basically, it was a combined trial. So you can see the details of the trial in NEJM. What they found was there was definitely improvement as far as with vitamin E. There's actually improvement in SGPT, SGT, but also hepatic steatosis and inflammation was also seen benefits, but there is no benefit of fibrosis. Okay, so there's no fibrosis benefit seen. But mainly you saw benefit as far as NASH is concerned. The steatohepatitis reduction was seen. So keep that in mind while prescribing vitamin E. It has probably antioxidant properties, which again, probably just like glutathione, that is where it probably acts. It's a safe drug. So I think there should not be any problem. And vitamin E can be considered for non-diabetic patients with, right? But there is no fibrosis reduction. And again, you cannot use it in diabetic patients because they do not show benefit in diabetic patients for some reason, right? So PIVEN study did show some benefit, and I think that makes it a good option for potentially considering. Now, there's a new study which has been published in Indian Journal of Endocrinology and Metabolism about growth hormone. Again, an investigational thing. This is actually a systemic review by, again, Dr. Deep Datta and Dr. Lakshmi Nagendra, both friends of mine. So let me just clarify, it's a, they're friends. But having said that, it's a very well done systemic review. You can see the full trial there. They actually looked at investigational role of growth hormone for MSLD. And remember, these are adults without growth hormone deficiency. And they actually found that there was benefit as far as the MR spectroscopy is concerned, the liver fat. There was actually liver fat reduction with MR spectroscopy or MR-PDFF. But again, mainly liver related. This is again a systemic review of clinical trials which are done, right? So what they are saying is that short-term growth hormone therapy, 6-month therapy, can reduce intrahepatic fat and may have benefit in these patients. But again, you have to be careful. It's not approved for this particular purpose. It's again very early to really consider this as a therapy, but just a potential eye-opener as far as is concerned, right? What are the future directions? So let me just summarize the thing here in the entire treatment spectrum. So you have a patient with MSLD. You have to see where does the patient stand. Does he have diabetes or does not have diabetes? Does he have obesity, does not have obesity? Does he have cardiovascular risk? Generally assume that they have. So these are the things you have to look at baseline assessment. Then you have to look at where do they stand as far as the pathophysiology is concerned. Do they just have steatosis? Do they have steatohepatitis or do they have fibrosis? So that is where you need to look at. And then you have to see the potential treatment. Now, resmetirom and saroglitazar have been approved in MSLD across the board. Resmetirom is not available in India, so probably saroglitazar becomes a good choice. Secondly, if you see the use case in diabetic patients, you have options of GLP-1, you have option of SGLT2, and you have option of pioglitazone. Of these, pioglitazone has shown fibrosis reduction also, but it has potential side effects and contraindications. So you have to keep that in mind. Amongst GLP, all GLPs are not the same. So tirzepatide has shown benefit as far as fibrosis reduction is concerned. Semaglutide has not shown that. And SGLT2 inhibitors have mainly done studies with MRI where they've shown fat reduction. Again, we don't have data for fibrosis. So all these things makes these drugs potentially good options. But remember, the treatment there should be primarily aimed at diabetes and not at the MSLD. The extra benefit of MSLD you get is something you should take it with with you. Other drugs, UDCA, no histology benefits. OCA, some benefits, but risk is very high. I mean, not very high, but other side effects are there. So, and it's not approved again. So whether should you consider using when you have other drugs? Questionable. Vitamin E, non-diabetic patients should definitely consider using. Why not? There is clinical trial to show its benefit. 800 international unit per day. So these are all drugs which you can use. Lifestyle measures, weight loss, 5 to 10%, 7%, 5 to 7% reduces fat, 10% reduces fibrosis, right? So that's what you look at in the terms of treatment. Some upcoming therapies will be there. Diet, as far as diet is concerned, Mediterranean diet is useful. Comorbidities should be treated. Statins, aspirin, if indicated, should be considered for these patients, right? So this summarizes the entire treatment aspect. We'll take some MCQs and some final questions from you before we end, and then I'll tell you how to get your certificate for this course. And thank you all for attending once again. And thank you to the LIPAGLYN team for I think, sponsoring this and being part of this entire event. I think it's a, I mean, it's something which was very close to my heart. It's something I wanted to do for a long time, to actually have a dedicated, structured system for MSLD, because it's a disease which we are going to all, I mean, we are treating diabetes, we are treating obesity. MSLD is something which, now we have so many, currently MSLD is the most, the most common reason for developing cirrhosis has now moved away from hepatitis B and C and alcohol to MSLD. That's become the biggest problem now. And add alcohol to that, you are in a worse state, right? So, yeah, so let's pull the poll questions and take your questions. And then we'll see the certificate process. Okay, so another case scenario, you can see, this is a lady, liver biopsy shows F2 fibrosis. After discussion about bariatric surgery as treatment option, she has showed expected outcome to her liver disease. So how does bariatric surgery help? So this is MCQ 1. Second is again a patient with abnormal liver enzymes, hypertension, amlodipine. You have liver biopsy showing NASH with F1 fibrosis. And right. So what is the expected benefit with vitamin E? Okay, so we can try this poll out. Meanwhile, we'll take some questions from your side, and then we'll ask, you can then raise your hand, unmute yourself, and okay, what does improvement in fibrosis actually mean? So there's reversal of fibrosis. So on a liver biopsy, we'll find the the fibrosis, the septa, the fibrotic septa is formed. There is reversal. Oh, okay, good question, Chandan. You asked. I think this is there is in fact a study where they looked at coffee, and I think all the I would say I think we missed that. Great point, right? I think it should have been an important point. So I will answer this. Yes, black coffee. Remember, black coffee and not coffee with milk. Black coffee without sugar has been found to be beneficial in some studies with MSLD, right? So I'll put if I find that study, I'll put it up in the technochronology group. So thank you, Chandan, for raising this point. Dr. Amit. Oh yeah, thank you so much, Dr. Amit, for being a part of this. And I hope we have this technochronology platform. You can explore some other courses there. We had this year in review, which we had done a few months back in December. So you can check that out as well. I think that will be useful also. And thank you all for being a part of it. And thank you, Dr. Amit, for attending these lectures. So let's take these MCQ questions which we had asked. And if you have more questions, keep putting up in the chat, and we'll discuss this in a few minutes. So yeah. So the first question, what is the benefit? So would there be complete? Yeah. So the first question, steatohepatitis, there is improvement of 59% following surgery. There is 30% reduction of fibrosis and 59% reduction of steatohepatitis. Second question, vitamin E has, I'm sure, sorry, these are numbered questions. So, sorry for that. They're not great questions. But yeah, so yes, so most of you got the answer correct as far as vitamin E is concerned also. Right. So we'll then tell you how you can get your certificate. Okay, so let me just pull up this. So what you need to do is, to get your certificate, you need to go to technochronology.com. Okay, so this is what it will look like, and you need to go to this course, right? If you're not signed up, please sign up, right? And kind of this course. Yeah. So this is what the course would look like. Now, to get your certificate, you should. This is what is the requirement from the platform. Right. So what you have to do is, you will have to go through each of these. You have to go through each of these content, right? All of them, and just have to click continue. You can see the bottom over here. You can have to click continue. Keep doing continue. There'll be quiz questions you will have to answer. All the quiz you have to answer. Again, go to continue, right? I mean, whether see if you already attended it and you don't want to read, fine. You just click continue and you can move next, right? And even the quiz questions, if you don't get 100% correct, that is fine. Okay. There'll be certain calculators like this, for example, fast calculator and so on. You can again try it out and click continue. Now, one thing which you can't skip are these reflection points. So this reflection you have to answer. You can see this Manan. Manan is basically reflections of your learning. So all these Manan sections you have to compulsorily answer. And then keep going next. So once you start answering everything, once you start going next, it will start showing this orange symbol, right? Orange symbol means you have completed that, right? So just have to keep going through this, completed. And then in the end, once you complete, it will automatically pop up saying that you can now get your certificate like this, something like this. So when you click on that, you'll be able to get your certificate. So this is the certificate. This is how it will look like. It will carry your name. This will be the same name with which you are registered on Technochronology platform. So if your name is incorrect, please go and re-register with a different name, with your correct name, right? You can actually copy this, download this certificate. This certificate, you'll have the issue date, and there is this unique certificate ID. So every certificate will be uniquely coded, and that ID is there in the certificate itself, right? So you'll be able to download this certificate and save it, and you can share if you just copy this link also, you'll be able to share this with your friends and colleagues on social media. Yeah, right. So this is what the certificate, this is a PDF of the certificate, and you can copy this link and you can share that link on any platform, and anybody can see your certificate, right? So this is what it will look like for you. Okay. So yeah, so I think we can end this entire session, and thank you once again to all of you for being a part of this, and thank you to LIPAGLYN Zydus Healthcare team for being a part of this again, right? Yeah, thank you so much. And yes, Dr. Jayesh, you're right. Fibroscan is available to anybody of you, right? So anything, anybody from Zydus wants to add anything? Chandrahas, are you there?
Yeah, sir. Good evening.
Good evening. How are you?
Yeah, nothing, sir. Like already you briefed it, sir. So yeah. Actually, I'm in the train. So thank you, sir. Thank you once again for all your expertise and all the sessions, sir. It was excellent, sir. And we'll catch you in person. Anything, sir, like which you wanted to develop from our side. Because our endeavor will be there to create a such program in going ahead as well, sir. So where all doctors can get the benefit of the certification course as well, sir. Thank you, sir. Thank you for all your efforts, sir. Thank you so much, sir.
Thank you so much. So thank you so much for helping me with this entire thing. They're very helpful in every stage of the development of this, session from Zydus. And, hope to have more such sessions in future with liver, with metabolic diseases, right? Now you have, empagliflozin also coming up with a lot of, with Zydus also. So I think, we can probably have something on heart failure as well. So we'll catch you soon. Thank you so much. And anybody wants to add anything or have any question or something you want to kind of think? Yes, thank you all. Yes, Chandan Kumar, you can. Why not from Zydus authority? There's no authority, Chandan. Don't worry about it. Okay, you are the authority, right? So yeah. So the weightage is actually from learning. So I think that is where I'll add to that. You can have my signature. I can probably add it if it's possible. I just see. Yeah. So yeah, So yes, you'll be able to access this course. Yes, we should make it available till end of the year, right? Till of course we have some fresh content coming in. I think we'll probably keep this on, so you will be able to access this later also, right? Yes. So thank you and good night, everyone.